Now we're going to talk about the spinal cord syndromes, right? I've been kind of bringing them up all along, so now we finally get to talk about those. A couple of words that I'll be using a lot: ipsilateral and contralateral, right? Ipsilateral means the same side, contralateral means the opposite side. Okay, I'll start with the simple one, a complete transection, right? What will be a complete transection? If you have an injury, it goes right across the spine. Boom. That's a complete transection. And below the site of injury is affected, right? Because the nerves can't get to there, the nerves can't get back up from there. So now when I talk about these other ones here, you're going to have to remember how the different tracts went. The spinal thalamic tract, right? It crosses over, and so some of your effects will be contralateral. The opposite side of the side where you have the injury to the spine, and I'll show you what I mean here. First one I'm going to talk about is kind of a fun one. It's Brown-Sequard syndrome. A guy named Brown-Sequard. I thought it was two guys, one named Brown, one Sequard. I just found out today, or yesterday, whenever, that it's one individual named Brown-Sequard. I don't know. Who cares? But anyway, this syndrome here, one half of the spinal cord is destroyed. Big injury, World War I was a common injury then, and it was really looked at real closely then. I believe it had been found earlier than that through sword fighting and stuff, but during World War I, a real big thing was when you got somebody down to go through and stab them right in the middle of the back, right? If they were down and you thought they were dead or you weren't sure they were dead, just one good stab right in the middle of the back and do that to people. Anyway, a lot of these people would end up, boom, and that bayonet would come through and destroy half of their spine, because you've got the spinal column with a good ridge right there, right? And it'll go and it'll deflect it down one side, and you can end up destroying half. This side's still intact. Now let's see what kind of symptoms that's going to do. You look at your at the patient and you follow the nerves, right? So, person is going to move, right? He wants to move. This is the damage he's taken. He wants to move his arms. Well, starts over on the opposite side of the brain, comes across here, crosses up in the brain, and comes down. Boom. Well, he can move that side, right? So he can move the side over here that doesn't have the injury on it. Let me use a better marker. All right, comes down here, boom, crosses over there in the brain, comes down like this, boom, down out the spinal thalamic, and boom, all the way out, right? So it made it. Now what about the other side? He wants to move the side, the affected side, right? This is the side, the affected side, because it has that damage on it, right? Knife just put that big old hole in that side of the spine. So he wants to move that arm, so of course it starts over on this side of the brain, comes across here, down, boom. So the ipsilateral side is affected as far as movement is concerned. Now, let's say you are testing this patient for pain. So anyway, now he wants to move this arm over here. This is the arm on the side that's not affected. This side over here, my spine is injured. This side is not. So, and I want to see if I can feel pain on this side, right? Well, the pain is the blue one. It goes in through the dorsal nerve root, comes here, it crosses over to the spinal thalamic tract, and it comes on up, bump. It ran right into that injured area. Can't feel pain on the opposite side of the injury. It's kind of odd because they can move this side, but they can't feel anything on this side, right? Now the ipsilateral side, they can't move that side, but they can feel pain over there. That kind of stinks, right? Can't move it, but they can feel pain there. And then as far as the other sensation, proprioception and that stuff there, that there is not contralateral, that is also ipsilateral. So, and I just want to do this here though. I want to look at one more thing here as far as the pain. Let's step back again. Sorry about this, guys, but step back again to the pain. Now let's see the pain on the side that's affected, right? The affected side. So it comes in here through the dorsal root, crosses over, decussates, right? And then it hits the spinal thalamic tract, and it comes right on up, all the way up to the brain. Boom. Yep, he definitely can feel pain on that side. So the ipsilateral side, the side that has the lesion, they can feel the pain. They can't move that side, but they can feel the pain. So they can feel pain on the side that's affected. They can't feel pain on the side that's not affected. They can move the side that's not affected, but they can't move the side that is affected, right? So the only thing that's opposite is pain, cold, and heat. Remember that. Those three things are contralateral. Those three things are contralateral. All the other stuff is ipsilateral, is on the same side as the lesion. So you got to remember, if you can remember that those three things will be the opposite of all the other stuff. The proprioception, sense of vibration, all that kind of stuff will be on the same side as the lesion. And that's Brown-Sequard. So that's one of the lesions. We will have these on slides too when we go over the slides. And I'm going to talk about this one. Don't really test on it because I think it's pretty unusual. But there was a girl in that had this problem. Was hitting the back with a steel pipe, and it ended up crushing her spine right in the back. And the damage that she suffered was to the dorsal, which makes sense. The dorsal side, the back side. And what it did was it destroyed, I believe it was her lower thoracic spine, but it destroyed the dorsal white columns. Everything else was intact. But what she didn't have was she didn't have the sense of vibration, the sense of proprioception. Those were the big things. And I took care of her when she suffered the damage, and I took care of her a couple of times after that. And she was kind of a very pleasant but quiet girl, but she would tell me that she has to watch her legs all the time because I can't tell where they're at. And she says, I'm kind of obsessed with moving them around. So, you know, she kind of would always make sure that she looked down at her legs and make sure that they were in a decent place. And she just said, you wouldn't believe how often you just move your legs around and stuff and without thinking about it. But she says, she says, I can lay there and lose circulation in my legs real easy, so I'm kind of obsessed with it. And she was telling me that because she was kind of just kept moving a lot, and she was just kind of explaining to me why. And I knew what kind of injury she'd had, so I understood. But anyway, what she had was posterior cord syndrome. It's not one of the ones in your book. It's not one of the ones that I'm going to test you on or anything like that, so I just brought it up because I happen to have a personal experience with it. I'm going to talk about anterior cord syndrome. So we've talked about Brown-Sequard. I brought up posterior cord. Now I'm going to talk about anterior cord syndrome. Anterior cord syndrome means that the front half of the cord of the spinal cord is all affected. And the reason you have circulation coming through, and it comes out like this, and it reaches out and feeds the spine. Well, this circulation, there can be an injury, some kind of if it's in the cervical area, it's usually from a flexion injury, and it can cause damage to the blood vessel there that feeds that part of the spine, or it can be some kind of a tumor pushing on it, or it can be coronary artery disease. It can be a stroke. Like I was saying earlier, sometimes you can have a stroke in the spine. Well, this can be a stroke to a portion of the spine, and that usually happens right around T4. T4 would be what we call the watershed area of the spine. It just means it's the area that has the least circulation. So if you really have like you're in shock and you don't have good perfusion, you might get this. You might get this if you don't get the person's perfusion up. You might get this just from lack of blood supply to that area. But what happens is you don't get the blood side supply, so you get ischemia and eventually a necrosis to an area of the spine due to lack of blood supply. The things that affect it are the whole anterior surface, and actually all the way, the 2/3 of the anterior surface. The only part of the spine usually preserved is the dorsal columns. They have a good collateral circulation. They have a supply of circulation from another vessel, so they are spared, but this part isn't. So that means that the person below the site of injury, that person will lose the motor, right? So they have paralysis, and they will lose their sensation as far as pain, cold, and temperature goes. Some of their touch, and some of their touch will be intact, because that is split between those two, between the spinal thalamic and the dorsal columns. That's why I haven't really brought them up much. The telltale ones, though, the hot, cold, and pain, will definitely, they won't have that, and they will be paralyzed to all areas below the site of the lesion. So that is anterior cord syndrome. Now let's see what else we got to talk about. Talk about Brown-Sequard. Oh, central cord syndrome. Central cord syndrome is a fairly common one. Central cord syndrome is fairly common, and it's pretty unique in its presentation because it's the opposite of all the other ones. So far I've been saying wherever the lesion is, from there down is what's affected. Above it is not. Well, this one they come in with an odd presentation because the upper extremities are more affected than the lower extremities. And this is what happens. It usually will happen from an extension injury, especially in an elderly person, not really sure why. I have seen diagrams that shows the head pushed back, and these here guys, these vertebrae, get pushed forward. As the head gets pushed back, they get pushed forward, and they press, and they press on that, squeeze that spinal cord, causing damage to it, and they get bleeding and edema in the spinal cord itself. What that does is it causes the edema in the middle, right? As fluid leaches out through the central canal, and you get bleeding, it tends to affect this area in the middle. And it pushes on all, and that edema pushes on your corticospinal tract, your spinal thalamic tracts, from the inside out. It pushes on this side. And so why does it affect the upper extremities? Is the way these guys are arranged, the tracts. Now what the tracts are is they are the nerves all going up and down, right? The axons traveling up and down these tracts, and then they exit out where they need to exit out. But they're not willy-nilly. They are in these tracts in a specific order. The upper extremities are on the inside of the tract, and way down at the bottom, the lowest extremities are on the outside of the tract. Right? Inside of the tract, upper extremities, out here, lower extremities. Right? So as you get edema pushing from the middle towards that, it's pushing towards it. Let's do this in a big black marker. Boom. So the inside of all of these is what's getting the pressure. So it may be affecting the lower a little bit, but it's affecting the upper extremities more, just because the pressure is hitting each one of those tracts from that side and on the inside of those tracts, and that medial side, that inside portion, is where the upper extremities come down, and then they exit out from the inside and keep going. Then the tract keeps going down with the lower ones. And that's why central cord syndrome affects the upper extremities more. Have seen this. In fact, it was a lawsuit with one of the docs, and it was this was what had happened. But anyway, and it was just like a tingling in her fingers and nothing anywhere else. Doc thought it was, from the accident, thought it was just anxiety and, a little bit of hyperventilation, because she was hyperventilating a little bit. She was breathing at like 22, 24. So. But anyway, it wasn't. Unfortunately, it wasn't. It was this. And I heard an odd thing. They called him the walking paraplegic. Now you say a quadriplegic means that both arms, both legs are paralyzed. The paraplegic means both legs are paralyzed, right? Well, these are walking paraplegics because their arms might be paralyzed, but their legs might not. Now, I've never seen them at that point. In fact, I haven't heard of them, but I just heard that term today used on this for this syndrome. And I guess it could happen, but it would be a pretty severe syndrome. And if they would be able to walk, it doesn't seem like the upper extremities would be totally paralyzed, but what do I know? Okay, let's see what else we got here. Cauda equina syndrome and conus medullaris syndrome. Very similar, and let's go. If you look way down at the bottom here on my picture that I have down here at the bottom of the spinal column, right at about L2, you've got the conus medullaris. That means that's where the spinal column ends and you go into the cauda equina. And it continues on down through the vertebrae and exiting out through the rest of the vertebrae, but it does it in a lot less organized fashion. In fact, I'm going to draw this a little bit different. Right, so if you look here, I kind of drew it on the side here. So this would be down around L2. And you have the conus medullaris, which is the terminating portion of the spinal cord, and then from there on down it's the cauda equina, where you have the axons of the nerves traveling down alone and then exiting out as they go. So when you get pressure on this, this is usually caused cauda equina syndrome and conus medullaris. Conus medullaris could be damage to the conus area. Cauda equina syndrome is usually damaged down in here, and it's usually a disc, and it's pushing on these nerves. As you can see, these are not as organized as this is organized, right? When you're over there, that's not, the cauda equina doesn't have that same level of organization, right? It just kind of got these nerves coming out, but when you put pressure on these nerves, it can affect everything down below, right? You might get, and you don't know what it's going to be, it might get numbness and tingling, it might be something with the bladder, with the bowels, loss of control of the bowels, and then you might also not have the feeling. There's this thing on YouTube about a poor lady who had cauda equina syndrome, and she was incontinent of bowel and didn't even know it because she couldn't feel it. And she started crying when she talked about it because she was walking around in public with this all over her pants. Now that's a very severe case of cauda equina syndrome, but it's something that can happen. So now one thing to know about this is all of these nerves down in the cauda equina are actually lower level nerves, right? So in the conus medullaris, of course, you have the upper level coming down to it. So in order for a reflex to happen, now we've got to stop and think about how reflexes work. I talked about them already. We talked about them. Right? It takes the peripheral nerves. They have to be able to go carry the sensation to the cord. It arcs over, and then the motor nerve has to be able to carry back. So in order for a reflex to happen, doesn't matter if the upper motor neuron above it is damaged. The reflex can still happen. In order for it to happen, you have to have those peripheral nerves, the lower level nerves, have to be intact. You have to be able to carry the sensation to the spine. You have to be able to carry the motor back to the spine. So very likely, or very easily, you could imagine, since all of the nerves in the cauda equina are peripheral nerves, lower level nerves, and they are what's being affected by cauda equina syndrome, you got to stop and figure reflexes will be affected, right? You're going to lose reflexes to the areas down below there, very easily could. And one of the important reflex down there is your bowel and your bladder, right? So how does a person pee? You got to stop and think of how that works. Your bladder, right? It fills up. That detrusor muscle, it gets a certain amount of stretch on it, causes a reflex. It sends that message, hey, I'm full, sends a message up here to the conus medullaris, boom, hits the reflex arc, motor nerve sends a message back down, and that sucker contracts to push the urine out, right? So, I might have to pee right now, but I'm not peeing my pants. Well, that's because that reflex comes and I have a sphincter at the bottom of my little bladder that I can hold on to it with, right? So I'm holding the sphincter right now, even though the detrusor muscle is saying, hey, you gotta pee, it's full. I'm saying, no, I'm not gonna pee right now because it's not convenient for me to pee right now. What has to be in place for that reflex to take place? The same thing for any other reflex to take place. You have to have your lower motor neurons intact, right? Your sensory peripheral neurons and your motor peripheral neurons, right? Those are the lower neurons. Your lower level neurons, your lower level nerves have to be intact. So that means that the bladder has to be able to sense it, and that nerve has to be intact to take it back up to the conus medullaris. Then, in the conus medullaris, it hits that arc and goes over to the motor nerve, and that motor nerve has to be intact in order to send it back down to the bladder to tell the detrusor muscle contract, right? So that's what has to be in place in order for that to happen. It's your lower motor neurons. The upper motor neurons, it can be anywhere up above there, they can be screwed, right? Might not get to the brain, but it doesn't need to, because this is a reflex thing. So if you have an upper level injury, you lose your ability to hold the urine. So I talked about the reflex for making you go, but that ability to hold the urine comes from up here, and it has to be able to make it down there. So what happens? It fills up, the reflex happens, and you pee, because you're not able to send that message all the way down there because you've got an injury up in the upper motor neuron. Now that's not what happens when you're down here in the cauda equina. When you're in the cauda equina, what's wrong is these are all lower motor neurons, right? They've synapsed here, and then they go out, and then they head on out. So they're lower motor neurons, so they care. In order for reflex to take place, they have to be intact. Well, if you have pressure on these guys from a slipped disc, and it might not be real even pressure, it might be a little bit more less predictable, but if that pressure happens to be affecting the nerves from the detrusor muscle that carry the message back up to the spine, right? So let's say that it's pressing on one of those nerves, one of those sensory nerves. You can't get that reflex because the detrusor muscle spreads out. Boom! It says it's time to go. Sends that reflex out, but it goes up and it gets impeded here, hits this spot here, right? Boom! And it can't get up here, so it can't get up there to create the reflex arc. And maybe it can. Maybe the motor neuron on the way back down is affected, so it won't tell it to do that, right? So one of those lower level neurons being affected, the bladder will lose its reflex ability. Or that's what happens in cauda equina syndrome. And the reflex takes place in the conus medullaris. So if there's conus medullaris, there's a real good chance that you also will lose the reflex, because that's where the reflex takes place. Maybe it's destroyed there where you have the arc and stuff, right? So right at that spot. And maybe it isn't for there. But down here, if it's affecting those nerves, you won't have that. So now, if you have an upper motor neuron injury, you don't have that, or you still have that reflex, but you don't have the ability to hold it. So you just pee. Fills up, you pee. You can't stop it, right? Neurogenic bladder is what they'll call that, and boom, it's just, yeah, and it's an urgency, right? You have to go. And then the other one, this one here, is an overflow. If you have it in the cauda equina, you don't have your reflex intact, so now the thing just fills up and it doesn't go. It just keeps getting bigger and bigger and bigger, and you start dribbling, right? Because your bladder's always full because that message doesn't get through. But this is very common. This happens a lot because older people a lot of times have problems down there with those lower vertebrae, causing pressure on the cauda equina. So, so what's the treatment? This is the easy part. This is the great part. Two different things. The treatment's the same. Cath them regularly. Cath them regularly, right? If they have the neurogenic bladder, because if they have the spastic bladder, that's what you can call it. That's a spastic bladder, which means that when it fills up, it just goes, right? So fills up, boom, it goes. A spastic bladder. If they have that because they have an upper motor neuron injury to the spinal cord, you have to. What you want to do is you want to cath them, teach them to cath every couple hours. You know, don't wait till you feel like you got to go because it's too late. Boom, you're going to go. Right? As soon as that reflex hits, you're gone. So you have to keep emptying your bladder before it gets to that point in order to prevent that incontinence. And now if it's the overfill, it's the same thing. Don't let your bladder get full so it overfills. You have to get on a regular self-cath regimen so that you're emptying it. That's the easy thing about it. You don't really even have to memorize what the difference is between those two types of incontinence, but because either way, the treatment's the same. You're going to be treating them the same. And when you start working, you're just going to know, oh yeah, this guy has spastic bladder, or this guy here has overflow incontinence, which is overflow incontinence is probably what you'll see the most. It seems like that's what I always saw when I was out there working.